to everyone. Thank you. So I'd like to introduce my co-moderator for the afternoon session, Dr. Dana Powell. Dr. Dana Powell is a board member of the SCAGO, as I mentioned earlier, and she has written about 8 publications, very, very interested in ensuring that sickle cell care in Ontario is optimal. So welcome, Dr. Dana Powell, as my co-host this afternoon. Our group 3 hospitals this afternoon, I believe her, group 4 hospital this afternoon will be University Health Network Hospital for SickKids. And we also have Dr. Derek Chen, formerly of the Michael G. DeGroat School of Medicine at McMaster University, who will also be presenting on his project on evaluating health resources utilization patterns in sickle cell disease in emergency departments in Ontario, which I'm proud to say that SCAGO was a co-sponsor of this project that Dr. Derek Chen did about 2 years ago. Without taking much of your time, I would like to introduce the members from the University Health Network. We have Ms. Ruth Apia Boateng, who's a registered nurse, Dr. Jennifer Bryan, an emergency physician, Ms. Kathleen Azubuk, who is a social worker, and we also have Ms. Jane Ballantyne, who's also from the patient relations. She's a manager of the patient relations at UHN, and we have Ms. Sindhu Srikatan, who's also a social worker working at the red blood cell disorder clinic at the UHN. Just a point of correction there, Kathleen Asabuke is maybe a social worker, but she actually works with Jane Ballantyne in patient relations. So we would let the University Health Network do their presentation. Thank you.
Thank you so much, Lenore, for the introduction. It's been another fantastic day at the summit today. I continue to take notes as I'm listening to all these great ideas. I'm going to be working the slides in the background. I'll be speaking a little bit later on, but I'm going to turn things over to my team members. Cynthia, would you like to get us started? Now, correct me if I'm wrong, I don't actually see Sindhu on the chat right now. We might go ahead to Jane and Caitlin's portion while she's getting connected. All right, Jane and Caitlin, would you like to get started?
Sure, yeah, no problem. Caitlin, are you there too? I think for some reason, we're both signed in under the same name, but I think she's changed that now.
Yes, I'm here. Cynthia's actually typing in the chat. She's asking if we can hear her. So I don't know if there's an issue with the microphone. I can start, but just wanted to let you know that I think she's trying to get connected.
Great, okay. Why don't you go ahead, and then Sindhu, once your mic is working, you can join us again.
Oh, hi everyone, I'm here.
We can hear you. Okay, great.
Okay, sorry about that. So hi everyone, my name is Sindhu and I'm a social worker in the Red Blood Cell Disorders Clinic at UHN. So just wanted to give you a little bit of context about UHN. So the Red Blood Cell Disorders Clinic is the largest sickle cell clinic in Canada, and it's the second largest in North America. So we serve a lot of patients across the GTA with diverse backgrounds and life experiences. And at our clinic, we have an interdisciplinary team to deliver the comprehensive care. So we have hematologists, we have 2 nurse practitioners, we have 1 social worker, myself, And we also have a transition navigator who's helping young patients coming over from SickKids. Go to the next slide. So I just wanted to briefly discuss the role of social work. So generally social work, we are, social change profession, and we work towards empowerment. We work with individuals, groups, families, and communities. And our core practices include relationship building, holistic assessments, emotional support, and advocacy. And when you think about the role of social work in sickle cell care, we address the social needs as part of the comprehensive care model. So some of my work includes help navigating community resources, programs, and systems. I provide mental health support as well as linkages to the community so for help dealing with anxiety and depression. I also support patients dealing with different life transitions, such as coping with illness, grief, navigating school, employment, and relationships. And then advocacy, as I had mentioned, is a huge role. So helping people, really get the resources, the benefits that they're entitled to, and making sure that they get equitable care and treatment in different systems in healthcare as well as in other places in society as well. So that's just a bit about my work. I'm going to transition it to Caitlin as well as Jane to talk about their work in patient relations.
Okay, so hi there, everyone. My name is Caitlin Ezebwicki, and I am a patient relations advisor with the University Health Network, and I'm joined by my manager, Jane Ballantyne. And the purpose of our presentation today is just to really go over some of the data that has been reported to our office by our sickle cell population at UHN, and then to discuss the ways that patient relations can assist sickle cell patients on their hospital care journey. But I think overall, our goal today in attending the summit and the panel discussion is really to gather suggestions and recommendations from the patients with lived experience, families, and staff on how we can continue to improve our service. Because I know our name has kind of been mentioned a few times in the session and in the chat. So I'd just like to start off quickly by explaining why we have a patient relations process, and I'll try to go through the slides quite quickly and get to the data and some case examples. So we have a patient relations process in the hospital so that patients can share their feedback, compliments, and complaints. We're able to provide education, navigation, and support to patients around the hospital system and also with the hospital staff. We're also a department to provide a process for conflict resolution, where we are supporting both the patient and the staff to come to a resolution within the clinics and the inpatient units. We also are able to collect data about patient satisfaction, and that of course can help to improve opportunities for improvement within the hospital that are related to patient experience and safety. And then we are governed by the Excellent Care for All Act, and that's the legislation that states that every hospital in Ontario must have a process that reflects the patient declaration of values. I don't know if you can see it there, but we just have a little photo there of our patient declaration of values that we follow at UHN. And how to contact patient relations within the hospital. So we accept phone calls. You can email as well. We also take staff consultations. So Sinthu in the sickle cell clinic also sends referrals to our office when she has spoken to a sickle cell patient who would like to report either a concern or some feedback. Sinthu will reach out to me and I can connect with the patient that way. So I think that's important to note that not only patients can come to us, but staff can come to us as well for staff consults on how to improve their service with the sickle cell population. So what do patients tell us? So in patient relations, we engage with about 350 patients every month, or about 4,000 patients per year from across all of our UHN sites. So Toronto General, Toronto Western, Princess Margaret, and Toronto Rehab. A little under half of that number are what we consider to be a formal complaint, or someone that's bringing forward their care experience that they had within the hospital. And then about 30 to 40% of the cases are patients that are just looking for support navigating the healthcare system and UHN, because it is such a large institution. The issues that are raised are mainly around communication with staff, treatment-related concerns related to respect and compassion, care coordination, and wait times within the hospital, so especially within the emergency departments. In the last 4 to 5 years, we've only heard from about 40 patients who stated that they have sickle cell disease. We have seen an increase in the last year, which we hope is related to the work that we've been doing with the Sickle Cell Working Group and with SCAGO. So we have had an increase in calls and emails. I'll also credit Cynthia for that, because she sent me quite a few referrals as well. So that's been really helpful. Many of the complaints that we receive are related to the emergency department and the general internal medicine units. And they usually involve issues related to, as we've heard many times today, they're usually related to pain crisis and response time from the staff on managing pain. And then also around disrespectful or uncompassionate communication by the care providers. So I did want to go over just one case example of a patient who came into our emergency department that I was involved with. So the patient arrived in our emergency department with their partner. This was unfortunately during COVID. So of course, the patient's partner could not come into the emergency department with the patient. So the partner attempted to provide suggestions to the nursing staff on how to manage the patient's pain. Because they had developed a plan together as partners on the things that really help him in the moment. At this time, the patient was in so much pain that he couldn't even communicate his own needs. So he did need his partner there for support. The patient's partner really felt that she was kind of being pushed off to the side, not heard by the staff when she was trying to communicate these suggestions. There was mention that the patient didn't look like he was in a lot of pain, even though he was in so much pain that they actually eventually had to bring in a wheelchair. Ultimately, the partner felt as though she was being dismissed, and she ended up contacting our office for assistance. So this patient goes through a lot of what our patients go through, in that they come through the emergency department and in some cases are eventually admitted to the general internal medicine unit. So what I did as a patient relations advisor was reach out to the general internal medicine unit as well as the ED and let them know that there was some communication issues between the nursing staff and the patient and his partner. I communicated the suggestions that the partner gave for managing the patient's pain. And then I tried my best to link the emergency department staff with the general medicine staff. So there was that continuity of care. I also reached out to the social worker on general medicine, who was able to then follow up with the patient and his partner. And she kind of continued the advocacy from there. So this is something that we hear a lot in patient relations, that a patient will come in, feel that they're not being heard, feel that their pain is not being managed adequately, and they really need someone to be there to advocate for them. I think part of the issue comes with patients not always knowing that we exist, and therefore not knowing who to reach out to. I will also go over some other reasons why they may not reach out to our office. But I would say the main reason being they either don't know that we are there, or they're hesitant to come forward and put in a complaint, of course, for fear of repercussions. So just looking ahead at some of our goals in patient relations and with the Sickle Cell Working Group, We know that even though we have a low amount of data for the amount of patients who reach out to us, that of course doesn't mean that these issues aren't occurring on a regular basis. So we need to really figure out what the reasons are for why the patients are apprehensive to reach out to us, and then address those accordingly so that patients feel more comfortable reaching out. We need to look at ways in which we can make our process more transparent, supportive, equitable, and accessible so that patients can really feel comfortable speaking up for their own safety. And I know this has come up a few times today within the session, but we understand that patients may feel comfortable coming forward to share with our office. So one thing that I have discussed as well with the working group is the idea of anonymous complaints. So that's come up quite a few times. I think Jane and I are now looking for further suggestions, recommendations, especially when we're on the panel discussion, looking for ways in which we can continue to improve and to make the patients more comfortable. So any type of suggestions or recommendations are welcome, and so that we can incorporate that into our process. And so the last slide there, I think, just has our email address. So anyone, please feel free to reach out to us directly at any time, even if it's after the conference, just to give any recommendations, suggestions. If you have questions, we'll do our best to answer those. We just really look forward to hearing your perspective, and especially the patients with lived experience. I think we would love to know any recommendations from them on how we can improve. So I think going forward, we've kind of done our best working with the working group, but we still have a long ways to go. So I just wanted to acknowledge that, and looking forward to the panel discussion.
All right, thank you so much, Caitlin and Sindhu and Jane in the background there. We're going to be talking briefly about the emergency department next. I'm also keeping an eye on the time. I want to make sure we do have some time for questions at the end. A year ago, almost to the day, many of you here joined UHN and SCAGO for our very first collaborative patient-provider forum with the emergency department. At that time, we made a commitment to keep building community and to keep working toward improving care for people living with sickle cell disease.
Our goals were to focus on building a partnership, create a standardized order set that aligned with the clinical handbook, and complete education sessions.
And what Ruth mentioned around community partnership is really the core of this for us. And that's what we've been hearing really in the past, these past 2 days of the summit. So we reached out to patients, we reached out to advocacy groups, so the Sickle Cell Awareness Group of Ontario and the Sickle Cell Association of Ontario as well.
Our ED working group consists of our emergency nurses and physicians, as well as our social worker, patient advocates, the SCAGO and SCAO organization, as well as our patient relations. We have about monthly meetings to continuously improve and refine our care for our sickle cell community. And we want to provide good, equitable health care.
And we've had a lot of discussions over the past couple of days about order sets. We've been using an order set at UHN for a number of years, but we knew that there was a lot of room for improvement there, that we had specific concerns from patients that we'd like to see incorporated. If our order set is helpful to anyone in the process, there is a link at the bottom of the screen, and you can use the QR code as well to have a look and see what we've been working on. So the order set, the revision was approved just in September. Some of the highlights for the changes are an explicit statement around that 30-minute target for analgesia. We know that we're not there or close to there yet. Like Dr. Verhofstadt said, this in some ways can be an aspirational goal, but it's still a very important goal for us. We included a statement about non-pharmacologic coping strategies. So hearing again and again, including in Fitzanne's talk this morning about misconceptions around what pain looks like, right? So how people will be seen on their phones or computers or eating a sandwich and will be documented as saying, you know, looks well, not having any pain. But again, what we know is that if we're not asking, we just don't know what people are feeling. So support for non-pharmacologic coping strategies and recognizing those as an important modality for managing pain was important. We also wanted to include a clear statement that only patients who feel ready to go home should be discharged from the emergency department. And so that's to encourage that conversation right from the beginning to make it clear to patients that they have power over what's going to be happening to them in the emergency department.
Our education session objectives were to have our patient advocates provide emergency education to our emergency staff by sharing their perspective of their lived experiences of how it is when they're having a pain crisis and coming to the emergency department. We wanted to create awareness. We wanted to decrease stigma, judgments and misconceptions that they were having. And we wanted to encourage the use of the order set even before the physician sees the patient. And of course, lastly, as Dr. Bryant said, highlight the importance of administering analgesia within a timely matter of 30 minutes. Unfortunately, the pandemic raised a lot of barriers for our working group to overcome, one being the inability to actually have our patient advocates come to the emergency department, and two, we couldn't have large group education sessions. So what we ended up doing is we worked in collaboration with both managers at Toronto General and at the Toronto Western site. Each morning, the managers have morning rounds with the staff where they talk about safety concerns, change in policy and procedures, and any concerns that the staff may have. So they allotted us about 15 to 20 minutes where we were able to create awareness, promote the use of the order set, and even have a Q&A period for the staff to ask our patient advocates some questions. As well, in addition to that, we were able to get our nurse educator to add Sickle into the new higher education when they come to the emergency department. This is a picture of myself and Serena Thompson, who is a member of the SCAO organization, and that's how we actually did our virtual education sessions. In reality, what ended up happening is we were successful at reaching 72% of our nursing staff at the Toronto General site, and we were able to reach about 19% of our staff at Toronto Western. We were successful at creating awareness among our allied healthcare professionals, such as our social worker, our gem nurse, and our consulting physicians. But most importantly, we wanted to create word of mouth and increase awareness within our department. We recognize that we have a lot of work to do and that we're just touching the surface of this. And we realize that the same amount of time that it takes to build these unconscious biases requires the same amount of time for them to change.
So in addition to the huddle education sessions that Ruth was talking about, we also held grand rounds, again, involving our patient partners in having a direct, direct discussion about firsthand experiences. We also participated in teaching session for over 1,000 students from health disciplines at University of Toronto. This was the first time that the Center for the Study of Pain had included a sickle cell talk in their sessions on chronic pain management. And so these are 1,000 future physicians, nurses, physiotherapists, pharmacists who are going to know that much more about sickle cell than they would have had they done their training even a couple of years ago. Now I'm going to invite our student, Marcus, who is an example of this very exciting future of medicine, to talk a little bit about the quality improvement project and the baseline data that he has to share.
Thank you, Dr. Bryan. So in order to appreciate and communicate kind of the impact that the work that we just discussed may have, we need to understand where we're coming from. And this research is really just showing some of the numbers that that highlight where UHN is at when it comes to providing timely analgesia. And this summer, we looked at 228 emergency medicine encounters spanning about a year time before the pandemic began. And this included 98 patients, about half of them were female, and the rest were male. And what we saw was about 50% or a little under 50% of the patients received a triage score less than 2. And we know the clinical handbook recommends that patients receive a triage level of 2, which deems them emergent. And this is an area of improvement that we could possibly look at. When it came to the time to analgesia, we noticed that only 5% of the people actually met that 30-minute mark that we were speaking, and the rest of the encounters that we looked at were above that. And the average wait time to receiving analgesia was 103 minutes. And another thing that we saw, which we're going to study, is if half of those encounters actually receive opioids before even seeing a doctor. So if these people receive their opioids quicker, then maybe this is an area that we could also look at for improvement. Lastly, I want to just say that the next steps is we're going to compare our sickle cell population to other pain presentations in the emergency room, and to see if we're doing worse or the same, and determine and use this as the baseline for the future changes that we're making to see where we're coming from.
Excellent. Thank you, Marcus. So we're very excited about the next steps of this project. To help us understand where we want to be, we need to understand where we are. And so that's the starting point. And hopefully with much more to come in the coming months to years. So thank you all very much. And I'm looking forward to the questions in the Q&A.
Amazing. Thank you very much to the UHN team. Today, we've seen from all of the panelists from UHN how there's an interdisciplinary collaboration. And it's great hearing from social work, patient relationship, the healthcare providers, in addition to seeing the importance for patient advocacy, in addition to seeing how the team has incorporated research into making certain decisions and driving forces for improvement moving forward. It was really amazing to hear about the new higher education and the huddles, and we commend you, and we're super excited also about the collaborative forum that you have shared with SCAGO a year ago, and moving forward what we can do as a team. So thank you very much for every member of this panelist who shared from UHN. So moving on to our SickKids Hospital speakers today, I would love to welcome to the platform Dr. Ann Fuller, who is a pediatrician, and Dr. Melanie Kirkby-Allen, co-director of hemoglobinopathy program in the Division of Hematology and Oncology at SickKids. So please feel free to turn on your cameras and you can take it away. Thank you.
I think Melanie is going to get us started. Dr. Kirby, are you there?
Is my camera on and can you hear me?
We can hear you perfectly.
Yeah, thank you. And thank you everyone for attending, and thank you for having us present to you. So we'll at SickKids, there are 3 of us on for today, and we will go through just a few ways that we're trying to optimize care for children with sickle cell disease. Oops. Oh, okay. So the model of care at SickKids. So at SickKids, we have a large dedicated sickle cell comprehensive care program. And this is mainly an outpatient, in the outpatient setting with dedicated people running sickle cell clinics 3 every week. Our inpatient care is managed by the pediatric medicine team when patients come through the emergency room with consultation, with hematology consultation and involvement. We have, as part of our multidisciplinary team, we have 2 nurse practitioners, one of whom is entirely sickle cell disease, and one is transfusions, both thalassemia and sickle cell disease. 2 registered nurses, one again dedicated to sickle cell disease and the other transfusions, and in both areas. Where we don't have enough social work, 0.5 social worker, which we share with the other 0.5. She's in oncology, but she really does her best to provide care to our patients when they need it. We have a clinic coordinator that we share with the rest of the hematology oncology clinic. We have a clinical research nurse, a transition navigator who will speak to you later, just to talk about the transition navigator, because I know members of the Ministry of Health are on, so I have to take this opportunity. This is an excellent, relatively new position, and we share 0.5 with SickKids and 0.5 with the UHN. The transition navigator position at the UHN is fully funded by the Ministry of Health, that's our understanding, and it's soft money that funds our transition navigator here with us at SickKids. So it's from year to year, nothing is guaranteed. And this has made such a major impact on our patients transferring over to the adult program. We have 3 hematology physicians who are involved with sickle cell disease care and also with other hematologic condition clinics. Neuropsychology program, which is 0.2 position. We run, in addition to the 3 sickle cell kid clinics, we have a newborn screen clinic. These babies come out between 40 and 60 every year in Ontario, in our catchment area, and that's nurse practitioner run. Melina is our nurse practitioner. We have access to subspecialists in dialysis for apheresis, bone marrow transplant, nephrologists, renal, lung specialists, as many people. They're not physically in our clinic, but our patients go to their clinics, and we try very hard to bundle all of the visits in the same visit. It doesn't always work that way, but we try as best we can. I'll ask James now to talk about the transition navigator position.
All right, thanks, Dr. Kirby. Can you hear me?
Yes.
Great, okay, and I'll just ask for you to forward the slide when I'm ready, okay?
Yes, sure.
All right, so thanks for having me this afternoon. My name is James Bradley, and I am an occupational therapist, and I work as the transition navigator, as Dr. Kirby mentioned. So I do work in that role between SickKids in the hemoglobinopathy program and Toronto General Hospital within UHN. So I'm going to tell you just a little bit about our transition navigator position today, as well as some things that we've been working on more recently. So I thought I'd just start off by sort of giving you a visual description of what the transition program looks like. So we can see on the slide here, I do start working with patients around the age of 12. So you can see on the yellow bar in the top there is the patient ages. So during that time, I work on transition preparation skills, which I will go into more detail shortly on the next slide here. We can see at age 18 is when the transfer to adult care occurs. So we support patients until they're 18 at SickKids. And sorry, I didn't mention in the hemoglobinopathy program, I work with patients with both sickle cell disease and thalassemia. So when they do turn 18, that's the time that we transfer their care to our adult team at Toronto General Hospital. And then I do continue to see them at Toronto General Hospital for 1 to 2 years, usually concluding when they're about 20 for that post-transition support. So the transition navigator role really does span ages 12 to age 20 at the 2 different healthcare organizations. Next slide, please. All right, so I thought I'd give a list of, on the last slide I said transition preparation, so that really does break down to quite a few different areas. So I thought I'd spend a bit of time just sort of explaining what areas I might be talking to patients and their families about in preparation for and during the transition period. So we can see here, I've started things at age 12, where I meet with patients and families to introduce the idea and the concept of transition, and that they will transition when they turn 18. We know that introducing this idea to patients and families at an early age is very useful, so they can start to kind of piece together what that might look like for them. So moving on from there, between the ages of 12 and 14, we conduct readiness assessments. So these are disease-specific assessments that look at things like disease knowledge, disease management skills, and also just a patient's comfort level talking about certain topics with their care providers. So conducting these between the ages of 12 and 14 allows us to then provide tailored education and support, which is done by the various team members that Dr. Kirby mentioned. So some of that might be done by myself. And then of course we have our nurses, nurse practitioners, social workers, and hematologists that might be implementing that education as well. So moving on from there, I do a lot of conversations with young people and their families about employment interests, volunteer interests, and then of course career interest as well, and planning for the future. We do a lot of work around making sure patients are connected to the right supports, both in the high school level, so secondary school, but more recently we've been doing a lot of work making sure that patients that do go off to college and university have access to the appropriate supports, which might be something like a school accessibility office. And for other patients that might be looking at work or vocational programs, we also connect them to support with that. Of course, between the ages of 12 to 18 and ongoing, working on health management skills with patients and families. So that's quite a broad sort of umbrella of skills and would be tailored to each patient and family's particular needs. Again, throughout those ages, connecting to any resources families might benefit from, whether those are community counseling or mental health resources, or other resources that might be in their local community. I might see patients twice or 3 times a year at the clinic, but making sure they connect to resources that are close to home as well. Of course, at age 18, we do our transition clinic. So this is a joint clinic with the adult provider. So Dr. Richard Ward from Toronto General comes over to SickKids. We do this once a month. So patients and families have a final visit with our SickKids team, and they get to meet one of their new hematologists from Toronto General. Prior to COVID, we would do tours of Toronto General Hospital as well, which we have not been able to do since COVID started. And then finally, navigating adult care. So this occurs, between the ages of 18 and 20, which I do find goes by very, very fast. A lot of this is, care navigation and really, really learning what the care system looks like. As many people on here know, the pediatric care system, especially for our patients with sickle cell, is very coordinated. So it's, a lot of appointments on the same day. We take care of a lot of those things, whereas in the adult care system, it really doesn't work that way. So I do a lot of support with connecting patients to how are they navigating their appointments, as well as ongoing support with the things I just mentioned. Next slide, please. So, our transition program has been around for about 8 years now, 4 of which I've been a part of the program. So I thought it'd be important to kind of briefly address, how are we evaluating this? How do we know the transition navigator is a useful position, or is it a useful position? So, of course, the question comes up: how do you measure successful transition? Although it seems like a pretty straightforward question, unfortunately, the answer is that it's kind of difficult. So there's not one thing you can look at to see if a transition to adult care is successful, and what does that even mean? So some key measurements that we do look at, and we have been tracking since starting the transition program, is of course patient feedback. So what's the lived experience of patients? We do that through interviews and through surveys, and those are ongoing. So we constantly get feedback from patients and their families about, what worked well, what didn't work well, what they'd like to learn more about in the future. So of course, the next thing is we can look at some of the metrics, some of the numbers. So transition clinics. Over 8 years, we've done 77 transition clinics with 342 patients that have transitioned to adult care since that time. So we know that looking at, how many of these patients are continuing to connect to care after they've transitioned to the adult system can be one kind of key measurement. Of course, looking at things like adherence to treatment. So whether that be medication adherence or, sticking to the recommended treatment plan, whether that be monthly blood transfusions or other. So looking at those indicators as well. as well as not only attending sickle cell clinics, but also looking at other specialist appointments. As we know, our patients with sickle cell do see a number of different care providers. And the final one there is quality of life. So this is something that, we've been doing the transition program for 8 years now. So we do have a lot of people, 342, that have gone over to the adult care system. So this is something that I really see as our next phase of research, and it's actually already underway. So we're going to be looking at patient-reported quality of life outcome measures, to see what the impact of being involved in the transition program has led to with more of a quality of life focus. So finally, I'll just talk about some ongoing transition initiatives. So we do always have ongoing clinical quality improvement projects. An example of this is the post-secondary accessibility supports that I mentioned. So this we worked on a few years ago, and now we are sure that every single patient of ours that transitions to university or college is connected with their accessibility office to make sure that they get the right supports in college and university. We also run patient education groups, and something I'm looking forward to maybe pursuing a bit in the future is helping facilitate some peer support programs. Research and evaluation, so ongoing patient feedback surveys, again, looking at medical outcomes, and then moving forward to more of the quality of life outcome measures as well. And that's all for me today, so I'll pass it back to Dr. Kirby and Dr. Fuller. Thank you.
So I think we're very proud of this program, and it's a program that we'd like to see duplicated in other comprehensive care centers, pediatric going to adults. What James hasn't said is that we know that in transitioning to adult care, we historically and in many other settings, it's well known in the literature, we lose patients from pediatrics to adults, and historically the highest cause of age of death between 18 and 25, because people fall out of care when they leave pediatric care. A few things are very different. One thing he mentioned was patients in the pediatric center. We tend to put together all the appointments. We get behind people to come. Parents are involved, and parents bring their children. When young people leave us at 18, that's a time of starting college, university, jobs. There's so many other competing things, and suddenly our 18-year-olds have to start advocating for themselves, have to make note of their appointments, have to keep their appointments, because parents then start giving them a little bit more independence, and things fall apart sometimes. So this program has, James hasn't said it, but our follow-up is significantly improved in the adult program in those patients who are transitioned through this program. The other thing not to forget, so that everybody's aware, there's an education session coming up on transition to university or post-secondary education, and that's in collaboration with the Sickle Cell Awareness Group, SCAGO, every year, and that's done. It will be done shortly. So I wanted us to highlight this program. We've run our comprehensive care program for many years now, probably close to 25 years or more. But we can still always do better in our program. We're not perfect, so we always look at ways of doing better. Back in 2016-17, the hospital looked at readmission rates of sickle cell patients and many other chronic illness patients, and earmarked sickle cell disease was one group of patients that were having significant readmission rates. At that time, our readmission rate was about 18%. Readmission as this definition of within a month, within 28 days of a discharge from the hospital as a readmission rate. And someone in administration decided that we should get down to 14% readmission rate. At that time, also in the United States, in the literature, it was about 16%. So we were aiming very high, a lower percentage rate. And that led to this program, which Dr. Fuller will talk about, called SCOPE.
Hi, everyone. So I'm a general pediatrician, so most of the time I meet children and youth with sickle cell disease when they come into the hospital and need to be admitted for any reason. So that's the lens that I bring today. But I'll be talking about this interdisciplinary working group that started just as I was arriving back to SickKids for my training. So Dr. Kirby has been giving me the tour. So this program came together with a goal of bringing together all the different healthcare providers in the hospital that care for children with sickle cell disease. And the target really was this readmission rate, as Dr. Kirby mentioned, but the goals of this program, I think, really reached beyond that to all the different things that can lead to suboptimal care for children and youth with sickle cell disease, which definitely that care is something that can drive readmission. So the program brought together representation across the department. So that includes emergency medicine, who unfortunately are at their major conference today, or else they would be here with us as well. Pediatric medicine, the pain team, and of course, hematology, who provides the comprehensive care, both inpatient and outpatient settings. We included a representation from the different health professions, which included physicians, nurses, pharmacy, and then our hospital's quality improvement and safety team, and the clinical and the administrative domains to ensure that we are capturing, all the different perspectives of the hospital. Next slide, please. So as Dr. Kirby mentioned, the goal was to reduce readmission within 1 month of discharge from 18 to 14%. And the main approach was to reduce variation in care. So that involved implementation of a variety of care packages to ensure consistency and to improve the transition home, to implement bundled services to high-risk patients, and then to prevent the symptoms and illness that lead to admission and readmission in the first place. Next slide. So there were a variety of clinical initiatives that resulted from that and have been evaluated, implemented, and reevaluated since. And I'm going to provide an overview. And then during the question and answer period, I think Dr. Kirby and I are happy to provide more details. So some of these included the introduction of a variety of clinical practice guidelines that have been implemented across the patient care environments. So these were reviewed by the multidisciplinary working group, updated. There was education provided to the care providers responsible for patient care in these settings. And these included care plans and practice guidelines for presentation with fever to the ED, to pain management, and to our approach to acute chest crisis. We implemented a standardized pain management program post-discharge called a pain plan, and that's really helped with ensuring that there's a smooth transition from the inpatient pain management program, sort of plan of action, to how things look when patients go home. We implemented modules for ongoing education for trainees and nurses about pain management. And then in some cases, care plans for individual patients where we've found that maybe our clinical practice guidelines need some more specific information so that when they present to the emergency department or get admitted to hospital, some details about their previous clinical trajectories or effective interventions in the past are well known from the beginning so that we can help provide the best care. And then some systematic education. And as a trainee, I think I was on the receiving end of some of this and really remember it well, to nurses, to physicians, to trainees, particularly about hydroxyurea. And, I've noticed as a result of this, our residents who really ask about hydroxyurea when patients come into hospital. And I hear about this now as the inpatient attending, even when it's not directly related to the reason for admission, everyone is thinking about it all the time. So I think that was a really nice program. Next slide, please. So looking back at that program, we really appreciated the fact that this multidisciplinary working group brought everyone together and led to some relationship building across the organization. So bringing together the inpatient, ambulatory, and ED settings. And, for example, even still, there's more work to be done because I didn't know all the details of that amazing transition program. It sounds really incredible. So we developed an engaged stakeholder group to address issues in a timely manner. We focused on standardized practice and best practices. And then in order to make sure that we had the perspective of lived experience, we now have a patient or a parent representative actually on our hematology oncology patient advocacy committees, so that we ensure that we're hearing the perspectives of patients and parents. challenges, specific to this program, we found that, we're able to bring people together within the hospital setting, but there's a lot of complexity involved in developing integrated partnerships with external agencies. So CCAC was one example. If we need home care nursing or other interventions to be done, like physiotherapy or occupational therapy in the home, that has taken some practice. And I know it's, I think, one actually upshot of the pandemic in some way, that some more automated processes are coming into place to make that happen. I'll just highlight, not specific to this program, but Dr. Kirby and I were talking about one other challenge is sort of integrating, like engaging patients in virtual care when that's our option. So we can talk a bit more about that in a moment. Next slide, please. So our next steps include, we've been talking about where we're going to go from here now that we've had some evaluation of that SCOPE program. So we're going to do a look back on all those care plans and practice guidelines that were implemented and see if a year or two later, after the pandemic has thrown a wrench in everything, especially if we're still adhering to those and if they're still working for our patients. We're reconvening our working group, and I think in some ways inspired by this summit and the feedback that we received, to determine if there are other quality metrics that we can evaluate going forward on an ongoing basis. We're going to continue to recruit patients and parents interested in participating in care improvement activities. And I think that the last step is learning more, maybe in a systematic way through research, as opposed to just quality improvement, about patient and family lived experience, to see if that can help us, think about other strategies for improving patient care in the three domains in the hospital: the ED, the inpatient setting, and the outpatient setting that they're receiving care in the hospital. I think that's it.
Yeah.
And Dr. Kirby, please feel free to add anything that I missed in there.
Just one, COVID really has put up a block, because our focus then went not away from patients, but in a different way. But one of the follow-up after the SCOPE optimization program, we were following the percentages of readmissions. And we actually, at 1 month, we got we did it in quarters. 1 quarter we got down to 12% readmission rate. We haven't looked for a little while, definitely not through the last 2 years, and that's something that we will have to look at again. And it's something we should keep doing ongoing. And look as Dr. Fuller had said, continue looking at all the other things that we did. That multidisciplinary group, actually, we spent so many hours in this room over like a year to get a lot of things done, and it was actually very gratifying to pull everybody together.
Thank you very much, Dr. Kirby, Dr. Fuller, James, and all of the SickKids crew. Thank you so much for that presentation. And we know that you are one of the programs that I know the pediatric families are saying SickKids is good, but thank you that you are still making efforts to improve your program. Thank you very much. So our last presenter for this segment is Dr. Derek Chen. Dr. Chen is a pediatric resident, physician scientist at British Columbia Children's Hospital with a research background in stem cell biology and interest in non-malignant blood disorders, including sickle cell disease and bone marrow failure. So he is on this summit today because previously he completed his PhD training at McMaster University, where he worked with Dr. Madeleine Verhofstadt in his clinical years to initiate a province-wide study of sickle cell disease quality of care in emergency departments across Ontario. And the SCAGO is very proud to be one of the sponsors of this study. And we thought it would be very appropriate for him to present this study today. Dr. Derek Chen, over to you.
Hi, Lonray. Thanks for that introduction, and thanks for giving me the opportunity to speak a little bit about our work. I just want to begin by saying that it's been a real pleasure to listen to all the stories from patients and then participate in the dialogue to improve sickle cell disease care during these 2 days over the summit. And so I hope to do it a little bit of justice by providing this sort of a capstone talk on our work here that looked at the quality of care for sickle cell disease in the emergency department across the province. The authors that you see listed here have no relevant conflicts of interest to declare. And I am mindful of time, so I'm hoping to also cover this as much as possible while balancing clarity as well while I go through the presentation. This work was really inspired by the clinical handbook that Dr. Verhovsek had presented to us yesterday. And this study was really meant to bring further data to bear on three main questions. One was, where is the burden of care for sickle cell disease in the emergency department? Two, are there identifiable disparities in sickle cell disease ED care? If so, what are their determinants? And then finally, three, where should or can we focus future interventions to improve the quality of care for sickle cell disease? To provide you a framework on our approach for the study, we first established the entire sickle cell disease cohort that presented with vaso-occlusive crises through a health administrative data approach by pulling data using the ICD code of D57.0. We then looked at establishing independent cohorts for comparison purposes that were matched on a variety of criteria. In these bubbles and below, you'll see that we had two tiered approaches for matching. One where we compared sickle cell disease to the general ED population that were made similar by age, sex, residential area, the neighborhood income quintile, and the date range of the ED visit. We didn't stop there, and we did a second comparison by looking at sickle cell disease with another acute on chronic disease entity called Crohn's disease that invariably at some points could present in the emergency department with a painful component. So looking at the tables below, you'll see the N numbers for the number of patients that we were able to capture using this matched approach. And in the subsequent slides, I will be able to show you our matched comparisons for match number 1 between sickle cell disease and the general population, as well as in match number 2, sickle cell disease versus Crohn's disease. And either in 2A or in 2B matched approaches, we were able to get in the thousands to hundreds and thousands of N numbers for comparison. And as this data has yet to be published, I would like to respectfully ask that this data would not be publicly shared without permission. So from a cohort to cohort perspective, we first looked at the entire sickle cell disease cohort population that presented with vaso-occlusive crisis. And starting on the left side here, you see that the representation for more than 2,000 patients in this cohort were a little bit more female compared to male, but within the emergency department setting, we saw the little bit of a flip where males were a bit more represented compared to females. From adult to pediatric, we saw about a 60-40 or 70-30 split in the patient representation, and a vast majority of these patients are living in urban environments. In the top graph, you'll see that the annual ED visit rate has been calculated, and you can appreciate that from 2006 to 2018, the average ED visit rate for patients among this cohort really increased steadily from about 3 visits per year all the way until 2018, which was about 14 visits per year. And from a cohort to cohort perspective, looking at the first graph here on the bottom left, you'll see that for the maroon bars, which represent the higher triage scores of CTAS 1 or 2, there is a larger representation of higher triage scores that sickle cell disease incurs compared to the general population, as well as in comparison to Crohn's disease. When we look at what the time of duration patients are waiting in the emergency department to be seen by a doctor, by general, even though with the same triage scores, we are seeing a significant difference where the sickle cell disease cases are being seen a little bit earlier by about 10 minutes or 15 minutes compared to the general population or to Crohn's disease. When we look at the disposition from the emergency department of either being admitted thereafter or being discharged, we see a larger proportion of patients with sickle cell disease being admitted to hospital compared to these control groups. And then in the longer term of the annual ED visits, we see that within a 1-year period, there is a significant 10+ year representation of visits per year in the sickle cell disease cohorts compared to our other control groups. We then conducted some subgroup analyses, and we looked within the sickle cell disease populations and compared them to our control groups. What we most prominently found was that adult patients with sickle cell disease have a greater burden of need and are not receiving equal or recommended treatment in the ED compared to pediatric patients. Starting on the left side of being in the ED, you'll see that a large ED visit rate burden is really found within the sickle cell disease population of about average of 6 visits per year. And that is a 2.5-fold change difference over the pediatric patient population. This is definitely not the case in the general population. And yet again, we see a greater fold change when we made our second comparison of sickle cell disease versus the Crohn's disease population, of showing that the burden is really highest among the adult populations. We then looked at triage scores, and we found that for an N number within the study, within the thousands, we found it quite significant that the adult patients with sickle cell disease receive a lower proportion of higher triage scores of CTAS 1 or 2 compared to their pediatric counterparts. And this pattern was not present within the general population and was still present a little bit within the Crohn's disease population. When we looked at the time that patients were waiting to be seen by a doctor in the emergency department, we saw a significant disparity between adult and pediatric patients with sickle cell disease. Adults here waited significantly longer compared to pediatric patients. We definitely do not see the same extent within the general population, and this significance remains even when we compare sickle cell disease compared to Crohn's disease here. What's interesting to also note from this graph is that when we look at adult to adult comparisons, adult patients with sickle cell disease are waiting about the same time when we compare head to head with the adults in the general population. But what's really driving the signal of disparity in care is that the pediatric patients with sickle cell disease are being seen much sooner compared to the adult counterparts, as well as even kids within the general population. Within the ED department, in terms of the time that's spent there, adults again are being seen, are spending a lot more time within the emergency department compared to pediatric patients. This is definitely not the same extent in the general population. And again, not the same case when we compare it to Crohn's disease as well. From the disposition advantage standpoint, we see that a less proportion of the adult patients with sickle cell disease end up being admitted to hospital compared to pediatric patients. This is not found in the general population. And again, this is not found in Crohn's disease. For the length of stay, if among the admitted patients, we see that adults with sickle cell disease remain admitted longer compared to pediatric patients. This is not the same extent in the general population, and we didn't have enough N numbers to really make a similar sort of discovery within our Crohn's disease comparison. And finally, in the longer picture of looking at the return to ED, we see that the repeat ED visit rates within either a 14-day window or a 30-day window is significantly shown here for adults with sickle cell disease compared to pediatrics. This is not the same extent in the general population, and again, significantly so not the same extent within the Crohn's disease population. Longer term, in the annual ED visit rate, what we found was that the 10+ bracket of patients were definitely overly represented in the adult patients with sickle cell disease compared to pediatrics. And by and large, it was really hard to find patients that had that same sort of bracket within the general population and in Crohn's disease as well. We also looked at sex as a potential determinant, and what we found was that male patients with sickle cell disease experience shorter stays in the emergency department and hospital compared to females, but their return rates are significantly higher. We see that their time they spend in the emergency department of males over females, they spend less time in the emergency department, not the same extent in the general population, and that this is also generally trended to be the case within our second comparison. And for the disposition from ED standpoint, for an N number into the thousands, this still remains quite significant, that males are less likely to be admitted compared to females. This is not the case in the general population, and again, not the case in the Crohn's disease population. For the length of stay in hospital, males are staying less in the hospital compared to females. This is about the same in the general population, but again, more significant when we made our second comparison to Crohn's disease. And in the longer term, we found that the repeat ED visit rates for males are significantly higher compared to females for sickle cell disease, not the same case in the general population, not the same case for Crohn's disease. And in the annual ED visit range, we see a slight overrepresentation of 10+ brackets in the black bars within the male cohort with sickle cell disease compared to females, and definitely hard to compare with the general population and hard to compare with Crohn's disease. We also looked at income neighborhood quintiles, and what we found is that the low income neighborhoods in sickle cell disease correlate with a lower acuity triage score and is a distinct risk factor for repeat ED visit rates. Looking at the graph on the left side, on the x-axis, you'll see that the neighborhood income quintiles are plotted, with 1 being the poorest among the quintiles and 5 being the most richest in the quintiles. And we see that in our comparisons of sickle cell disease versus general or sickle cell disease versus Crohn's disease, there is a heavier ED visit rate within the lowest neighborhood income quintile that we looked at. And interestingly, in the emergency department, we also saw a correlation with triage score. So patients with a lower income quintile, as represented by 1, generally were less likely to receive a higher triage score of CTAS 1 or 2, and that this steadily improved as you went up in terms of your neighborhood income quintile. This pattern was not found in the matched general population here, nor was it actually found in the Crohn's disease cohort as well. And then in the longer term of returning to the ED, we saw a heavier burden of needing to come back to the ED within the lower income neighborhood quintile populations of sickle cell disease here, compared to the general population where it's not to the same extent. And we see the same pattern where the absolute degree of repeat visits is certainly higher in sickle cell disease compared to the Crohn's disease population. We also see this correlation in the annual ED visit rates for the lower income neighborhood quintiles compared to the highest bracket. We barely see this within our control groups. And then what was interesting was that we also found that within the highest bracket of high users of ED visits, we found that the high annual ED visit rates in sickle cell disease are significantly less often repeat visits compared to the general population. So when we categorize visits of either 0 to 3 times a year, 4 to 9 times a year, or more than or equal to 10 times a year, certainly a proportion of the highest proportion of 10 visits a year could be explained partially by repeat visits in the emergency department. But when we compare to the matched population of the general ED population, a large proportion of the sickle cell disease population of coming that many times throughout the year isn't necessarily explained by our catchment window of either 14 days or 30 days compared to the general population, which really suggests that they are very distinct visits that are spread throughout the year. And then we finally found that triage scores may act as an example structural mechanism to improve the ED quality of care for sickle cell disease among adult patients. You can see in these graphs here, for the time that they wait to be seen by a doctor, it certainly steadily improves as the patients are receive a higher triage score, and that there is a correlation when we look at their likelihood of being admitted or discharged from the hospital with a higher triage score. Repeat visits are certainly less among those who have a higher triage score, and that in the annual ED visits rate, we also see a correlation where less of them in the higher triage score group will likely be within that group of 10 plus per year. So in conclusion, we found through this study very systematically that disparities in sickle cell disease VOC ED care remain present in Ontario for a universal and publicly funded healthcare system, and that the quality of care received in clinical outcomes for specific subgroups of patients within this group, most prominently among adults, but also among those more vulnerable within this patient population, raises concern from a health equity perspective. And so from now, the landscape of sickle cell disease care needs to really be addressed to address these gaps from a policy standpoint, from a clinical standpoint, and from a variety of research efforts in the future to make sure that we can provide better care for everybody. And while the absence of race-based data in our databases really limits our ability to assess for existence of racialized disparities, our matched cohort comparisons lend specificity to those that were identified in sickle cell disease here, and highlights the need for inclusion of such data in our systems in order to provide consideration of needs for vulnerable populations. So I hope that this future work will really build on this foundation of this data for our province for more than over the last decade. And I'm really happy to present this update to this group here. And we're happy to take feedback either by QR code, and I will paste this link as well in our chat. So thank you very much. I wanted to briefly thank Madeline Verhovsek for really giving me the opportunity to help lead this work here. We have established a brief research brief to circulate to the SCAGO community on the left side that will come out shortly. And again, here is the QR code on the right side to provide feedback, as well as the link to provide feedback on this work. This work was not possible without funding supports from SCAGO, as was mentioned, as well as from funding supports from the Division of Hematology and Thromboembolism at McMaster University. Thank you very much, and I'm happy to take questions with the rest of the panelists.
Amazing. Thank you, Dr. Derek Chen, for that eye-opening, very detailed, descriptive research study that you and the team have initiated. We feel very much enlightened by that, just understanding the demographics, understanding the burden that lies, understanding how it all encompasses into contributing towards the patient's outcome in the end. So we appreciate all of that very detailed study that you've shared with us. So now we'd like to invite all of our panelists who are part of the afternoon session. Feel free to put your cameras on, and we would like to open the floor up for questions. So this is our question and answer period. If you would like, I want to encourage all our guests and all our friends on the line today, please put your questions in the Q&A chat or in the general chat, and we will get to them. But first, just to start off, I have a question for our team, and I know anyone can feel free to answer this, but I know it was mentioned by our SickKids team. Dr. Anful, I know you've mentioned that there is quality metrics that are being used. So I'm just wondering, like, how are you determining, like, how is the team determining this quality metrics for evaluating patient care going forward? I would assume it's a consolidation of what you mentioned, like the clinical practice guidelines, you're encompassing research studies, knowing the challenges and how you're approaching them. So I'm just wondering, what is the team using for like distinguishing and understanding the quality metrics that need to be instituted for, I guess, best practice in terms of care of the patients coming in?
Dr. Kirby, do you want to start that one? And then I can add as we go, since you're part of the unit.
So for the last 2 years during the pandemic, things are not been going the way that they had started. But shortly after the scope optimizing program was put in place, there was ongoing with the help. So a lot of the detailed, the proper words for using some of these things, I follow along with our quality improvement team, but we would meet, and the quality improvement team would continue looking at readmission rates, for example, and give us every quarter and give us a report back. What we looked at, what is very clear, and Dr. Fuller had mentioned it, what is very clear is that the education within the inpatient service. So a lot of her colleagues who were residents at the time are now staff physicians. And so this current generation of staff physicians is much more educated about sickle cell disease and management. And that has come from 5 years leading up to this of increase in education and to everyone.
And I just want to add one thing that Dr. Carolyn Beck, she couldn't be here today, but was a part of preparing this presentation and is our inpatient director for pediatric medicine. You know, one of the points we've been talking about is actually defining quality metrics. So not that we have a list of quality metrics, but that, you know, our next step as a group is actually we had some initial ones that were part of that scope working group, but now thinking going forward, what are additional quality metrics? How do we define them? And that being the first step towards deciding, you know, QI interventions and measurement of those quality metrics. So I think, you know, we're even starting, some of them are obvious that we've already discussed, but some of them are ones that we don't know exist yet out there, but that's going to be a part of that, you know, those next steps that I mentioned, you know, those will be information gathering to help inform what our next stage of quality metrics will be. And obviously best practices can inform that kind of thing, but we're thinking about going beyond that and thinking a bit more broadly.
Looking not only readmission, but starting from the way we started with looking at the emergency room experience, and the repeat visits to emerge, the length of stay in emerge, the time to first antibiotic, for example, and time to first analgesia, and then the follow-up analgesia. So there's a lot of things that need to be looked at the moment.
Okay. Just a follow up to that question, just knowing all of these different aspects, every patient coming in has a unique story, has a unique, I guess, care plan, right? So for just knowing that, does that add another level of difficulty in terms of you layering on all of these different things for your metric system moving forward?
Getting the patient perspective, the patient narrative also will be part of looking at how we're doing, because we can look at numbers, but if the patients are not feeling like they're getting good care and adequate care, then it doesn't matter. So,
and I think to add to that, there's always the lens that we tend to take in health research when we're thinking about health equity and healthcare equity that looks at deficits and what's missing. And then I think there's another lens that we can apply as we learn the patient experience and implement going forward. What are the strengths that exist, and how do we learn about what resources patients and families are drawing? Where are their sources of resilience, and how can we integrate that aspect into the care that they receive as well? And I think that's one of the really unique things that every child and family brings, that their sources of support and the strengths that they have to draw on, and we can do it on a case-by-case basis clinically, but I think that there are high-level lessons to be learned about the strengths that families have when they're coping with a chronic condition like sickle cell disease that can help us. So there's the medical perspective where we have this level of metrics that we always think of, and then obviously there's the whole life that goes on when we're not there. So I think both need to be taken into account, but I think a strengths-based approach, could also add some value here, and that's something that I'm interested in personally.
Amazing, absolutely makes sense. Thank you so much for that. Just understanding of just the direction you see moving forward. I'd like to pass it over to Ms. Lanry for facilitating other questions.
Yes, we will look in the Q&A box and in the chat box. But before we look at the other questions, I wanted to ask the UHN team, especially in your presentation, you had provided that about 52% or so of the people that I believe in the survey that Marcus has shared, about 52% of the people who are part of that survey were provided opioids before a doctor's assessment. And I wanted to talk a little bit about that, given that many of the hospitals that I have interacted with do not think that patients should be provided with opioids without the MD giving the okay first. I just wanted to know if there's something we can all learn from that practice that you're doing. Thank you.
Thanks for that, Lanre. Maybe I can give a little bit of the MD perspective, but I think more importantly is going to be to hear from Ruth on this. Yeah. So Ruth is a fierce nurse to have on your side if you come to the emergency department and you're having pain related to sickle cell. So what Ruth will do, and I can say from my perspective, is she will come and she will find me, and she will say, hey, Ms. X is here and she's having bad pain. Here is the order set. This is what she usually gets. I know, that we're this many hours behind, but I really want to get her started on stuff. And so the fact that we, in that baseline data, we're having folks get analgesia before their actual, physician initial assessment time, really comes down to great work by nurses like Ruth. It is a very difficult topic. It is a controversial topic. We are not able still to start opioids before someone has a spot inside the emerge, and we all know how bad our wait times are. So a lot of people are just are out in triage waiting to come into the emerge. So we're definitely still facing barriers. But when it works, it works well. So Ruth, I'll let you speak to that.
Thank you, Dr. Bryan. That's a great question, Lanry. We are focusing on emphasizing with triage and the primary nurse. The moment we have a patient come in with sickle cell pain crisis, especially, for example, when I am in triage, I do tend to ask the patient what are their regular dose of medication that they take and what are their breakthrough dose that they take, so that when I go and get that actual order set and give it to the physician, I'm not only just asking for the standard 2 milligrams or 4 milligrams of hydromorphone. I'm saying they take, for example, 18 milligrams of hydromorphone and take 4 milligrams as a breakthrough. This patient needs a little bit more medication. Can you give me an order? And then we initiate it right away. We are pushing to let triage and the primary nurse work together. And what we're working on doing is actually having the order set at triage already printed in the triage room, so that when they bring the patient into the room, the triage nurse tells the primary nurse, this patient is having a sickle cell pain crisis. I'm going to talk to the doctor to get the order set ready for you. Get an IV in so that we can at least match the time and work in unison, so that by the time the IV is already established, someone's already mixing the pain medication and it's starting. We are holding each other accountable. I can tell you that much. As Dr. Ryan said, I am fierce to work with. So we are working with holding people accountable. I do check when I come into work if we have patients with sickle cell pain crisis. I do check when was the time they got their analgesia. If it's been more than 3 hours, I'm filing an incident report. We're getting management and we're trying to escalate it so that this conversation is being started. And not only file an incident report, I do talk to my colleagues and say, you know what, I hold them accountable. If this patient's coming with pain crisis, we need to start something so that they have a better understanding. We need more than just empathy. We need to have compassion as well for our patients. And I always say we have to keep that same energy. If it was our family member, we would advocate for them. If it was our friend, we would advocate for them. So we need to take the time to remember that they are one of us. We are all human beings. We all go through pain. We need someone to be there for them. And what can we do to make sure that, they're getting the adequate pain medication that they need? I hope I was able to answer your question.
Yes, that was good. That was powerful. And I want to thank you and your team at UHN for that. I also want to thank Dr. Derek Chen, because he has provided us with amazing study to help us see, even compared to Crohn's disease and other diseases and disorders, how sickle cell disease is faring when it comes to the emergency department. This clearly shows that we have so much work to do. There's so much more to be done. Before we get to the closing remarks, we're getting to the end of it. I wanted to ask all the panelists to kindly have their camera on, and Carla will take a picture of the Have to Know panelists. But while that is going on, I cannot help but note in the chat box some comment from Dr. Deji Ayorinde. This man is actually a psychiatrist, and he was one of the moderators for yesterday's session, but he did put something in there that I thought I would like to read out to everybody. The acronym is PREMS, P-R-E-M-S, and it said P is for physical pain, protocols, patients. And he has more stuff there, but I'm just stopping there. You can read in the chat, it's there for everybody. R is for respect, race, resources. E is for empathy, emotions, equity, education. M is for mental health, mentorship, management. S is for systemic issues, stigma, stress, support, sensitivity. He even added SCAGO. S is for SCAGO as well. I want to thank you, Dr. Ayorinde, for that. I think you really sum it up for us very nicely. We need to respect. Sickle cell is about pain, and he also has mental health, and there are systemic issues that we need to be working on. There's stigma, there's stress, there's support. And SCAGO, get to work, more advocacy. Thank you so much. That was amazing. So I would also like to use this moment to thank every member of the SCAGO research team, because without the research study identifying the hospitals in need of education to support patients with sickle cell disease in the province, we won't be here today. So that study led to today. So I want to thank every one of you. Most of you are still on the call. Dr. Susan Williams, Dr. Melanie Kobe. We have Dr. Madeline Verhofsek. We have Mr. Sanjeev Adwani, Dr. Soji Jamitola, Dr. Mami. All of you, I want to thank you for the amazing job that you've done with the study. I also want to thank all the moderators for the, for today and for yesterday. You did an amazing job moderating these sessions. I mean, you will agree with me that the last 2 days has been very impactful with eye-opening and program-changing presentations, both from the patient communities and the hospitals. So, and I want to thank every one of you for staying with us. And we hope that you've been, refueled, re-energized to drive equitable care for sickle cell disease forward in Ontario. You see, every one of us has a part to play, not just SCAGO, and not just the healthcare providers. The patients, you have your part. The caregivers, you have your part. And we all need to work together with them. And the Ministry of Health have their parts to play. Everyone needs to work together to provide, and do their part. So, without taking much more of your time, we have provided some evaluation because we wanted to hear from you on what else you need to do. You need to hear from us, what else we need to do, what programs needs to be in place, and how should we move forward. So I'm going to ask you to take 5 minutes and complete that survey that you receive shortly. And so on that note, I will hand it back over to Dr. Dana Powell if there's any other last remarks to see. But I'm seeing some comments in the chat box, Dr. Dana.
Yes, absolutely.
Would you like to look at those?
I am. I was just going to mention it, Mrs. Lanre. I'm seeing a lot of our panelists here who are also sickle cell warriors. Very grateful for the extent of knowledge and the sensitivity, the empathy that comes with the presentations and the comments, and just everyone who's spoken today, all of our panelists. I just wanted to read one in particular, if that's okay, from Katrina in the chat. Thank you, Ruth, and all the doctors, nurses, and healthcare advocates for being there. More like you will help to make our crisis experience in the emergency department go so much better for us. Immediate care helps to make recovery a lot easier and hopefully shortens the duration spent in admission, barring any other complications coinciding with the sickle cell crisis. Thank you. There seems to be a barrage of messages where it's a united front of gratitude for just the level of exposure, the improvements that are being made across the board for treatment of patients with sickle cell disease in the ED. So we would love to thank all of our panelists, all of our presenters today. Thank you for your contribution towards improving the care of our patients and also the caregivers. And we applaud you for the work that you've done today.